Psychiatric emergencies. Guys, the biggest thing that we're going to make sure, I'm going to make sure you guys are solidified on is your scene safety and your approach to these psych patients. Okay, we're going to talk about some of the different disorders, how they might present, but the biggest thing is going to be understanding how to safely approach and manage these patients, because psych patients, if they're having a behavioral emergency, they're very unpredictable. They can be cooperative 1 second and then become combative the next. So it's going to be a major part of talking about this chapter. All right, let's start off by defining what a behavioral emergency or a behavioral crisis is. This is going to go into play a lot based on what you get dispatched to and how you actually handle the treatment of this patient. How is it defined? Can you guys read today?
When a person responds to their environment and reaction.
All right, so guys, this is going to be what society deems as normal. If the society that this patient is in does not look at that person's behavior and think that it's normal, that's technically defined as a behavioral emergency. Keep that in mind as we go along in this chapter, okay? Because that is just so far from you, and we'll get there. I mean, yeah, I mean, it's all about subjective views and opinions. But if, yeah, I mean, that would, you know, the protesting and all of that stuff, that would be considered normal behavior versus the day that they're not normally protesting. Is that what you're saying?
Yeah, just what's acceptable one day versus the other day.
Yeah, kind of. Okay. So we start to go into this behavioral emergency when these people are acting outside of the normal perception of how that person should be acting. If they're starting to act erratic. Guys, what does erratic mean?
Unpredictable, kind of.
Unpredictable and kind of hyped up. Kind of all over the place. Yeah. You might be talking about one thing and then 10 seconds later you're talking about something completely different. And then, you know, you're kind of erratic and hyperactive, if you will, with your physical motions. They can start to become violent. They can become combative. But again, guys, some patients you cannot reason with, especially a psychiatric patient. If you have a patient who is having a behavioral emergency, like a true psychiatric episode, you are not going to be able to reason with them. The number one thing you have got to understand about these patients having a psychiatric episode is what? This changes your whole approach to your patient, your scene safety, trying to get these patients to cooperate. The number one thing you got to understand is what?
Like they're not fully conscious of what
Keep going down that path.
They perceive everything as a threat, like other stimuli around them.
Perception.
Like they're not really registering that you're there to help them. They might just be confused.
Guys, their perception is their reality, right? If you come on scene and I'm having a psychiatric episode and I see you as a threat, I see you as a two-headed purple alien, whatever chemically is going on in my brain to make me think that, it's not going to change. You can tell me all day long that you're not a purple two-headed alien and you're not here to hurt me. If I'm having that chemical imbalance, maybe because of drugs or just a chemical imbalance in my brain, you're not going to convince me. You cannot ever, ever, ever try to argue with a psych patient. It will never go well. Okay? So we try to learn to, in a sense, kind of play off of their perception and kind of work with what their current reality is to try to get them to cooperate with us. Okay, so we'll get there in a minute. But you got to understand perception is reality for all of these psych patients. All right, guys, technically, a mental disorder is even as simple as anxiety. Okay, you don't have to be labeled with the heavy hitters like bipolar and schizophrenia and, you know, borderline personality disorder to have a mental illness. Technically, anxiety, depression, OCD, obsessive compulsive disorder, is lumped into the mental illness is kind of a taboo way to put it, but disorder. Okay, PTSD also goes in there. Like agoraphobia. Does anybody know what that is?
That's fear of wide open spaces.
Fear of open spaces. So you have these people who just they never go out in public. They just stay confined in their, you know, house or wherever because they have a social anxiety or a fear of different things. Oh, the U.S. mental health system provides many levels of assistance. Do they really?
No.
Any better, but very
Their level of assistance sometimes is a pill.
Okay. I'm not filtering. I'm not going to get on it because I'm being recorded. I'm not going to get on my soapbox. But sure, guys, the American health system is so ridiculously broken. It is not funny. You know, for people who don't have financial means, people who have these mental disorders, getting true, appropriate help and resources is very hard to do. So because of that, you will notice a large population of the homeless patients you will see have significant mental disorders. All right, guys, so there is a spectrum, just like most everything we've talked about in here. You can be a highly functional schizophrenic. You can be a highly functional person with bipolar disorder, or you can be someone who is, you know, with medication, with therapy, with all of these other resources, just it's very severe, and you're not high functioning to the point where you can keep a job, you can pay your bills, you can go to these doctor's appointments. People on that end of the spectrum typically end up not keeping a job, not able to pay bills, possibly turning to drugs as an escape from everything that they hear and perceive in their head. So a lot of the homeless population is going to have some significant mental disorders because resources are very hard to feasibly obtain for the vast majority of those who need it. Okay, that's good, right? That wasn't like too soapboxy. Okay. So there's different ways, guys. There's medications to try to give a more balanced chemical level in the brain. There's therapy. You can go sit down and talk to somebody. You can do all of these different, like there's 12-step programs for mental disorders as well. So there's just all sorts of assistance if you can get it. So again, let's go back to the definition of a psychiatric or a behavioral emergency. All right, somebody's acting outside of norm, right? What are some reasons somebody could be acting abnormal?
Stressed out.
They're stressed. Guys, you might have someone who has a psychological break because they got a crap ton of stuff going on in their life. That person earlier that had that tension headache, right? This hypothetical person getting a divorce, their dog just died, their wife's trying to take the kids, they just lost their job, like all of that stuff. One person can only take so much until they break, right? So we could have somebody who doesn't have a history of any mental disorder and is having an emotional kind of breakdown because of everything going on in their life. What else can make you act abnormal?
Trauma.
Huh? Okay, so maybe they do have a mental disorder and they're not on their medication like they should be. Absolutely.
It can be doing drugs.
Drugs. Oh, drugs is a big one. I don't know if it's in this chapter or the toxicology chapter. There's some videos we're gonna watch.
Trauma.
What else?
They could have had some kind of trauma.
Trauma, like maybe a recent, so just intense stress, maybe a recent loss of a loved one, or maybe like an anniversary of the loss of a loved one or something like that. Significant date.
Because like for example, my grandfather, he suffers from PTSD. Sometimes he'll shout out military orders.
Yep.
And you have to actually talk to him like a soldier sometimes.
I guess, what about medical stuff? Hypoglycemia. Can you act altered and erratic and out of your mind if you're hypoglycemic? Yeah. What else? Hyperglycemia. Stroke. Hypoxia. Right? So again, we've got to get to the root cause as to what's causing this erratic, abnormal behavior before we just label, oh, dude, you just got psych problems, you're crazy, whatever, get in the back of the truck, we'll take you to Grady. Okay? Because you might be missing hypoglycemia by labeling somebody having a psych disorder. Right? All right, so guys, there are organic disorders where this is going to be it's inside of the body, okay? So we've got a physiological functioning issue. So this is going to be if we have hypoglycemia, hypoxia, all of that stuff that we just talked about, okay? Hypothermia and hyperthermia can also cause erratic behavior. What's the term? It's when you get significantly hypothermic. Maybe it's paradoxical something. I can forget the term. You should know what I'm talking about. You get so hypothermic that the nerves are painful and it feels like your skin is burning and you're not completely with it and you like strip yourself of all of your clothes. It's this weird phenomenon. Yeah, somebody look up and tell me what it is. I can't remember.
People are found like
yeah.
They get that warmth, take everything off and lie down.
Oh.
It's the best thing you ever have in your life.
Because you won't wake up. Functional disorders, again, this is going to be like those ingrained, those genetic, that chemical, schizophrenia, bipolar, all of that stuff that's not really brought on by an etiology of like hypoglycemia, hypoxia, stuff like that. All right, so guys, make sure, what are some things you think we want to do when approaching these psych patients or these behavioral patients?
Don't be threatening.
No. All right, don't be threatening, okay? How can we come across as not threatening? Introduce yourself. Why not? Be like, hey, my name is Kayla. I'm a paramedic with Grady. I'm here to help you. Maybe have that baseline introduction because, again, perception is reality. We have a very skewed uniform sometimes. People think that we are cops, and some people don't like cops, and some people won't cooperate with you if they think that you are there to, get them in trouble, take them to jail type thing. So, hey, I'm Kayla. I'm a paramedic. I'm from Grady. I'm here to help you. All right, what else do we want to do? Body language. What about it? All right, so yeah, make sure you're not coming on scene and standing like you're, trying to intimidate that patient. Okay, so be very mindful, guys. Sometimes I just regularly stand like this and I don't mean like my resting bitch stance, I guess. But that can come across as intimidating to some people. If they're already on edge and they already might not trust you, be very perceptive of your body language, like how you're carrying yourself.
So would you want to stand in a defensive posture?
Might want to what?
Not stand in a defensive posture?
No.
Full steel.
I mean, typically, keep your hands out of your pockets because they might wonder what you're doing with your hands in your pockets. But usually this is the normal kind of stance that is not going to be I'm about to, jack you up. Right. Or, I don't know, you could maybe talk with your hand. I don't know. But just avoid the crossed arms and the hands in the pockets. All right, what else about body language? What do I want to be looking at? Okay, so I want to have an appropriate amount of eye contact with my patient. right? Because if I come up on scene and I'm like not looking at them and I'm talking to them, how does that come across? That I don't care about them, right? But if I'm sitting here talking and I don't break that eye contact, and I'm just sitting here, you know, what does that come across as?
Like you're weird.
Yeah, like I'm, you know, like sizing them up, like, hey, try me. All right, so have an appropriate amount of eye contact with your patient. What else do we want to notice about our body language? Look at your patient's body language, right? What are some indications that this patient might already be perceiving me as a threat and is might not going to be cooperative? Okay, so yeah, notice if they've got their muscles tense, or if they're standing like this, or if they're walking around with their fists clenched. All right, so they're getting in that fight or flight mode, and they're going to choose fight, and you're going to be the target. Right? What else might be perceived from their body language that it might not be as smooth of a transaction as we want to be?
Maybe they're scared of me. Like they're somewhere.
Okay, so maybe they're trying to hide from you. Might be it.
If their eyes aren't focused on you, they might be hallucinating something.
Okay, so maybe we want to pick up on their eye contact too. On the same token, if they're like just having those, you know, those darty eyes, then I'm not really sure, you know, what their perception, what their reality is. But also, if my patient is not breaking eye contact with me, what are they doing to me? They're hyping me up.
Okay.
Can I take them? When's my opportunity to strike? Right? So be aware of your body language, pick up on your patient's body language, because that nonverbal stuff goes a long way. What else do we want to keep in mind? The distance between you and your patient. If you have a patient who's acting erratically, do we want to take the normal approach and be like, hey man, what's going on? All right, no. Hopefully you guys have got enough street smarts to perceive someone's body language and position and engage your environment to judge how you can physically approach the person. If not, we can have a side conversation. But yeah, guys, keep within what? Literally a swinging distance from your patient. All right, so if my patient's, you know, kind of tensed up, they won't break that eye contact, I'm just gonna, you know, safely approach, keep a good buffer distance between me and my patient. I'm not going to have any physical contact with my patient at this time. I want to stay out of striking distance from that patient if they decide to lash out at me.
Is there like a good distance?
No, that can be an oppressive distance. So yeah, sorry. What else? Okay, so your tone, absolutely. Your volume, absolutely. Do it. Yeah, pay attention to your surroundings, guys. Always have your head on a swivel, even if it's not a psych patient, right? Know where your exits are when you enter whatever scene you're going to. Never have your back to the patient. And guys, this is if you're perceiving that this patient is acting erratically, they're combative, they're agitated, we're not really sure how they're gonna respond. You've got some psych patients who they're seeing all sorts of things, but they're happy-go-lucky and you can go sit and talk with them. This is not every psych patient. This is just if we're perceiving that it could transpire. Never turn your back on the patient, because again, if they're having that whole I'm sizing you up, the second you turn away, what are they gonna do?
Go for it.
That's gonna be their opportunity, right? Know where your exits are. Don't ever get yourself like backed into a corner where you don't have a nice egress away from that patient. What am I missing? Okay, let's get there. Guys, let them know you give two craps about what they're, going through, okay? Unless you've been around psych patients a lot, or you know somebody who has psychiatric disorder, a lot of people just kind of brush it off as like, whatever, you're crazy. I don't care. I couldn't imagine like living with a significant psychiatric disorder. It's just constant turmoil day in and day out. All right. So let them know you care. And please, for the freaking love of Pete, I can't express this enough. This is a major pet peeve of mine. Try to always do what first?
Don't go straight for the restraints.
De-escalate. Do not get out of that truck with a mentality, it's my way or the highway, buddy. If you don't cooperate with me, I'm just going to tie you down. You're going to get what you give when it comes to attitude with your patient. If you have that mentality of, well, guess what? This is only going to end one way, and I can tie you down because you're acting out of your mind. What do you think they're going to come back with? If you go. If it's going to get physical, let's do it. Right. So, guys, please don't just have that, wild, wild west cowboy mentality. Try to talk to your patient first. Gather their response, see if this is a patient that you can get to cooperate. If not, that still doesn't give you a reason to have a douchebag attitude, be like, I'm about to tie you down to a stretcher. It sounds weird to say that, but there are people out there who have that mentality, and that's not okay. If that's your mindset about treating people, not the field for you guys, okay? Always try to de-escalate first. If it gets to a point where you are very aware that this patient's not going to cooperate, what do we need to have in mind? Huh? Okay, let's get some resources. Let's maybe get PD en route. Who else? Maybe family. If family's on scene, we can try to get family to de-escalate because they know that person, they trust that person. We can try to get them to de-escalate, but try to make sure that that family member is not also a what?
In that case.
Okay. Yeah, we had a call one time. We went there several times, but the worst time we were there, it was a guy, he lived with his mom, and his mom was always just like nagging him and riding him. He was having a psychiatric episode, and she was just like talking crap over there in the corner, and he reacted to mom. So we had to get mom like out of the house until he calmed down, and he cooperated once mom left. Right, so try to gauge if we can use people to help de-escalate. Who else do we need to have in mind? ALS, why? I can give the night juice, right? Because if you got somebody who is already uncooperative and agitated, and you come at them with restraints and saying, hey, I'm going to physically tie you down, what's going to happen to their hostility level? It's going to go through the roof. If your ideal world, guys, I know you always don't have ALS readily available. You don't always have fire or PD readily available. Ideal world, get PD and ALS on scene, have those drugs out ready to go, and everybody's got the same game plan. So if we're to the resort of physically restraining a patient, we need to chemically restrain them as well, because those soft restraints are not very strong, especially if they're on a stimulant. They're going to have superhuman strength. Those soft restraints are not going to hold them down, and you drastically piss them off by tying them down to a stretcher. Not a good day. Okay, please, please, please de-escalate first. Not all situations can be de-escalated, but have a plan, have backup in place before you start to physically restrain a patient. All right, so what's another thing we want to keep in mind? Guys, perception is reality, right? So this is kind of a fine line. We don't want to do what with these patients if they're having hallucinations. Maybe they're hearing something that nobody else is hearing. Maybe they're seeing something that nobody else is seeing. What should we try to do with that information? So yeah, maybe not straight up disagree with them, but we also don't want to what? We don't want to really like confirm it either. So if I have that same patient who thinks, all right, well, we'll do a different patient. You got a patient who thinks that the CIA is out to get them. Okay, so paranoia and schizophrenia often go hand in hand. So they can be having a schizophrenic episode where they're paranoid, the CIA is following them. Yeah, man, I just saw those two guys over there with the black hats and sunglasses. They're following me. They're going to get me. Like all of this stuff. I don't want to say what. Oh yeah, man, I see them over there too. I don't want to solidify their hallucinations, because what's that going to do to my patient's anxiety level? Go through the roof. All right. But I don't want to also say what. I mean, they're not there. You're seeing things, because that's going to have any kind of relationship with my patient, right? So we want to kind of play off of their hallucinations in a way that makes them think that obviously we are there to help. But, oh man, dude, if you're seeing those guys, let me take you to the hospital, because the hospital is a safe place. They can't get you there. Right? I don't want to confirm nor deny. I don't want to like discredit what they're seeing, but you got to just have a fine line of playing along with, well, if you saw them over there, let me help you. Get in the back of my truck. I've got the walls of the ambulance are impenetrable to sonar or whatever, right? Like they're not going to be able to read your mind back here. You guys have done it before.
I have a question, Professor.
Yes.
In those instances where you have a patient that is hallucinating at that level, would a acceptable way of handling as well be asking the person questions like, oh, what did they say? Or, you know, and then kind of, because sometimes, you know, with some people, you don't want to just, sometimes you can kind of, by putting them in that safe space, quote unquote, sometimes that can increase their anxiety as well. So would it be okay to say, oh, well, did they say that? Well, maybe for safety, we should do da-da-da-da-da.
So to a certain extent, yeah, if they're hearing voices in their head, then we want to know a little bit about that. Particularly, what's the number one thing I want to ask? Okay, so yeah, what are they saying? But are they telling you to hurt yourself or hurt anybody else? Okay, so that's going to be my number one concern. Are they going to be suicidal or homicidal because of these voices in their head? So I can elaborate, okay, well, if you're hearing voices in your head, can you tell me what they're saying? That's not saying, oh yeah, I hear them too. And that's not saying, no, you're crazy, you're not hearing voices. Tell me what they're saying, okay? Just be careful how far you kind of ride their response, but just let them know, hey, I'm listening to you. I don't think you're crazy, to try to build up that rapport, but just don't like solidify or amplify anything. That make sense? Mm-hmm. And guys, there's no black or white way, like textbook way to handle these psych and behavioral patients. It's just reading body language. It's reading the room. It's trying to understand, you know, how that patient is perceiving you, what their reality is, type thing. So the more psych patients you come in contact with, it'll be easier to kind of have that flow of conversation, but there's not one way you have to handle all of these patients. It's going to vary. Okay. Obviously, guys, they can also have some medical problems going on. They can maybe have some trauma injuries, especially if they are, you know, doing any type of self-harm, or they're on a stimulant drug and they're, you know, like bashing their head against the wall, or they're jumping through glass windows, all of that type thing. What's another thing we need to remember about stimulant drugs? Typically, you don't what? When it comes to pain.
You don't feel it.
I don't really feel it. All right, so especially guys like those the bath salts, or like the Flocka that used to be, had the surgeons a few years ago. I mean, there were people who were stabbed or shot several times while on this drug and did not waver at all. So the whole drug-induced psychosis is a whole other ballgame. All right, so we'll get there eventually. Just be advised that, or be aware that not all hospitals are the best resource for psychiatric patients. Technically, a hospital cannot deny you transporting a psychiatric patient to them. But in the Atlanta area, Grady and Atlanta Medical Center are really the only two hospitals that have appropriate resources to try to follow up with psychiatric care. If you take a psych patient to like Emory Midtown or St. Joe's, you're doing that patient a disservice. They don't have any kind of really follow-up or anything like that for psychiatric patients. So just know where you're taking them. Don't get complacent around your patient, guys. Even if you got them to cooperate, you know, get them in the back of the truck and get them on the stretcher or whatever it might be, doesn't mean that 5 minutes later, the voice in their head might tell them to do something different to harm you. So always, always, always keep your head on a swivel with these patients. I might even suggest that you don't worry about like documentation during transport, because that's normally if a patient's stable, we'll sit behind him in the captain's chair and work on our chart while we're en route to the hospital. What are you doing while you're charting? You're looking down. So just be very conscious about your surroundings, especially for the transport, because why? It's a very small space.
And it's moving.
And it's moving. There's not really a lot of easy exits in the back of that truck if the patient decides to become violent with you. And also, it's what?
Got all your stuff everywhere, they could potentially.
Yeah, so equipment. Guys, it's just you and that patient, right? Your partner's not back there with you, they're driving. Unless you've got, you know, maybe like a PD escort or something like that, if they're in custody or something like that. But again, just do not become complacent with these patients who are acting erratically. If they have any medical problems, we're going to treat them appropriately, manage ABCs, give any meds we need to give, any type of trauma dressings or treatment. We're not going to withhold treatment just because the patient has an underlying medical or mental disorder. Okay. Psychosis, that's going to be the major kind of term that causes these people to go outside of the given reality of their situation, right? So drugs, alcohol, intense stress, schizophrenia, bipolar, any type of hallucinations will play into this. It will kind of drive them to that state of psychosis. Schizophrenia, it is typically a genetic thing or a DNA thing. It's not, you don't really like, it's not a contagious thing. Usually all of these mental disorders until around the age of 25, 26, mid-20s, it can take that long for these disorders to present themselves. So hopefully I'm out of the woods. Some of you guys still got a couple years left. Again, schizophrenia, that paranoid is very much paired with schizophrenia, paranoid, schizophrenic. You hear that term a lot. Delusions, hallucinations, erratic speech. Okay, you're diagnosed with schizophrenia if you have 2 or more of these things consistently, when you have these kind of episodes where you're acting out of reality. Bipolar, all right, so this is, we will see there's usually a manic and a depressive stage of bipolar. Okay, the manic stage, they will be erratic, they will be, you know, hyperactive, their speech will be very fast-paced, higher self-esteem, they're gonna feel really good about themselves. They might like go and like clean the entire house because they're just full of energy, right? They might have a better perspective on things, they might be more positive in this manic stage. Impulsive behavior, that's another one. A lot of that comes with impulsive like purchasing. They spend a lot of money, some people, when they're in their manic stage, they'll go out and they'll just like go on a shopping spree. And then when we have that manic stage, it's like a roller coaster. We'll hit that manic stage, we'll be high, 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 and then we crash and we hit that depressive stage. All right, so it's literally like that term roller coaster of emotions. That's what bipolar is. So when we reach that high and we crash at the bottom, we've got the depressive thoughts of suicide. You don't think highly of yourself. You become kind of disconnected from social activities, loss of interest, low energy levels, can't really concentrate because you're in a depressive state. All right, so if you've just got somebody just going up and down, then bipolar is most likely the culprit. Excited delirium, this is just also just they're erratic, all right? They are just hyperactive. Hallucinations, delusions can become with this. Typically, this is drug induced, right? A stimulant, maybe like LSD, something like that. Obviously, guys, if it is a stimulant, we're going to see those physical effects on the body as well. Increased heart rate, increased blood pressure. They are going to be sweaty. Their pupils are going to be what? Dilated. All right. Yeah, guys, don't leave your psych patient who's acting erratically like by themselves in the back of an ambulance. They might harm themselves. They might
Run away.
bust a $45,000 cardiac monitor. They might run away. Yeah. Huh? Yeah, like 2 years ago in the middle of 75. Mm-hmm. Yep. Again, guys, ALS has different drugs we can use to calm these patients down or knock these patients out. So keep that in mind. If you just got a patient who is just not cooperating, let's get ALS en route so we can have those the chemical assistance with the patient's presentation. Guys, we've already talked about this. Is everybody good with restraint? Why we need to physically restrain somebody? Why do we need to physically restrain somebody? If they're a danger to themselves or others, and we're beyond the point of reasoning or de-escalating with these patients, right? Guys, this is last resort. I cannot stress that enough. All right. We're going to use the soft restraints. Ideally, I keep saying ideally, how many people do we need on scene to safely restrain a patient?
4. A lot.
I think you can get, but 2.
It can be done with 2. Trust me.
It's
But
safely 4. 5.
ideally, why?
First increase
Yeah,
limbs.
there's allowed.
So one person is going to be assigned to each limb to hold down each limb, right? And that 5th person is going to go do what?
Tie the restraints down.
Go around and physically tie each limb. In an ideal world, we want 5 people, 1 for each limb, and that 5th person is going to go around and tie each limb so that people holding those arms down don't have to move around to tie while they're holding. Usually don't get 5 people on scene, but ideally we want 5. Who else do we want in route? PD and ALS. In an ideal world. Let's see, is it here? Okay. So, on page 5. We'll watch these now. So, guys, there's so much that goes into this, that why this should be a last resort. Okay. Literally, it's more paperwork for you, right? Even if your patient is stable, if you have physically restrained a patient, you have to monitor their vital signs Q5, even if they're completely stable. So it's more work for you. Okay. Also, too, guys, we can significantly harm these patients if we are physically restraining them without a just reason, and if we are getting way too overzealous when we restrain these patients. Okay. What position should we restrain these patients in? Supine, lying on their back. Okay. Not obstructing what? Airway. Again, this is a very recent soapbox. I'm not going to get on. This is abused way too much. So make sure you have just reason that you're doing it, not because the patient pissed you off or you're trying to have cowboy mentality. That patient has to be putting themselves and other people, you and your partner included, in harm's way. Okay? Make sure you have appropriate resources at hand. ALS is going to be your biggest advocate, because if we can chemically get these patients sedated, it's going to be less of a physical struggle. Less likelihood that things can go wrong, harm can come to the patient, or you or your partner or your crew. All right, so just make sure that you're doing this appropriately. That's all I'm going to say. Okay? All right, now some comedic relief. Yes, please. All right, so we'll watch the funny one, and then we want to watch the bad one and then the funny one?
Yeah,
Let's watch the bad one first.
Distance has been on all of our minds, I think. That we've been too close.
Okay, little background information on this video we're about to watch. Guys, this happened 2018, pretty recently in DeKalb County. I think it was out in Decatur. This EMT decided to act inappropriately with her patient who was restrained. All right, so a little background story about what's happening here on the scene. This is a 17-year-old patient. So we have a minor patient who I think it was drinking or something happened. He was being uncooperative. So they placed the patient, I think he's in handcuffs actually, and they're in the process of restraining the limbs. The patient's still being uncooperative. The patient's on the stretcher. Patient is handcuffed in the process of being further restrained and spits in this EMT space. Now, I can understand why she wanted to do what she did. All right. I've been spit in the face before, and it takes you from 0 to 100 like that. Trust me, I know. But you cannot do what she did. She went ham on this guy. A, this is your patient. B, it's a minor. C, he's restrained, right? Hands behind the back. And D, guys, if you start to have that self-defense mentality, what do you have to absolutely justify? Why you did it, but why should you go from patient care mode to self-defense mode?
You're in danger.
If your life is in imminent danger, is somebody spitting in your face threatening your life?
No.
It'll piss you off, trust me, but it's not endangering your life. So yeah, she got fired. There's both civil and criminal lawsuits against her. She lost her license. She will never be able to practice in bare minimum the state of Georgia for the rest of her life.
Even if it's not affect your life, it's still like body fluid. So is it okay to walk away and say like we're putting a mask on?
Oh,
not
absolutely.
Until,
Absolutely.
Can you put like a mask on them? How do you handle
We
that?
have, do I have one in here? Ooh, hold on, real quick, be right back.
You ever see like online?
Oh, it's spit. Yeah, they put the bag on
not.
the head.
Also, Tasha, how is long because it's not a school facility week after that?
This is literally what we use. And this is literally called a spit hood. I'll pass this around, you guys can get your hands on it, but it's like pantyhose material. You know, you could use it for that. So yes, if you're physically restraining a patient, because guys, if you're physically restraining them correctly, what's the only weapon they have left? Their head, their face, their teeth. They'll try to bite, they'll spit. All right, so we will literally place this over the patient's head. It won't obstruct the airway. They can freely breathe in and out of this material, but it prevents any of that bodily fluid from getting on you. Okay, so yes, don't forget the spit hood.
But like, don't put it on unless you're active, right?
Oh, no. Unless your patient starts to spit at you or anything like that, we don't put these on. This is just, okay, you get one chance, and if you break that chance, you get this. Okay?
You were saying that Grady and one other area had appropriate.
Atlanta Medical Center. Yep. So you will also hear, there was like the raw body cam footage. I can't find that anymore. This is from the news and they're going to be talking over it. But at one point you'll hear, because this was caught on the body cam of a police, you'll hear that police pull her out of the ambulance because they arrested her because she assaulted this patient. And she was like, man, that mother effer spit on me. And he's like, I don't care. This is your job. Guys, that's part of being a first responder, being in public safety. Like it's not justified that a patient does spit on you. That's not okay. But that's part of the risk that we take being a first responder and putting ourselves in these calls and these scenes with these patients.
If they're like swinging,
You're really concerned about getting spit on, aren't
you?
you?
I don't want to put it on if no one spits on me, but if they're threatening to spit on me, is it okay to put it on before they spit?
As long as you guys, again, as long as you can justify in your documentation why the spit hood was placed on your patient, yes. If you have no reason, your patient wasn't threatening to spit you or they weren't actively spitting at you and they had a spit hood on, no, that's not okay. But yes, justify and it's okay. So yeah, don't be hurt. So guys, she just nails cover up.
I'm not staying on That is a kid. That's a 10-year-old child. What are you doing? You don't take that. This is your job. You do this for a living, right? It doesn't matter. Yes, it does. This is your job. If you don't like people spitting on you, then okay. This is not real life right now. You all right, man? You okay? Are you okay? Oh, my pants stop Yeah. I got her cargo pockets on that.
Yeah, so guys, I mean, what ended up happening is the EMT just, kept trying to say, I don't care. Like, I don't care. This is my job. You don't spit on me. Because the very beginning, you can see, like, she didn't just, like, instinctively, like, just have, like, she was, like, hitting the kid. All right? That's not okay. That's not, her life wasn't in danger. That shouldn't have happened. All right? She called her supervisor to tell her what was going on and thought she was going to get out of it. And she didn't. She got arrested, like, right there on the spot. So don't do that. Is that kind of clear? That we shouldn't do that? Okay. Guys, that was an AMR unit. That was very close to here. Okay? All right, so now comedic relief don't mean white when it comes to sedation either, okay? Or physical restraint.
New Arm & Hammer Clean and Simple is inspired by you, Dad, and the smart way you clean. Clean and Simple has just 6 essential ingredients for a powerful clean. Did we just have laundry? Yeah, we did.
Hey, what? Stanley? One way or another, you are going to come with me to make this sale. Can you just let me out of here before we get there? Don't worry, it's just a bolt tranquilizer. Nothing to be alarmed about. It's just a man pointing a bolt tranquilizer at a coworker. The wires do not
good? Don't be that auntie, don't be Dwight. We'll be good to go? Alright, talked about that. Guys, suicide is suicidal ideations leading to a depressed state where they're contemplating suicide or attempting suicide is something fairly common that you'll come in contact with. Couple things to keep in mind about approaching this patient or interacting with this patient.
If we don't want to aggravate.
So yeah, try not to aggravate them. Guys, be aware that you're not a licensed therapist. Okay, don't expect to have these patients who are depressed or contemplating suicide, you know, lay down on the stretcher couch in the back of your truck and you say all these magic words that are going to fix them. It doesn't really work like that. Okay, unless you can personally relate to anything that these patients are going through or feeling, don't try to. All right, it comes across as very not genuine if you're like, oh yeah, man, I understand that, when you don't have any of the same circumstances that this patient does. All right, just the best thing that I found to do is just kind of open that door and say, hey, I can't imagine all of this stuff right now. I've never been in your spot, but I'm sure it sucks. If you want to talk to me, I'm here. Right? So if they want to talk to somebody about it, or sometimes guys, they just want to dump. They might not have anybody that can like hear what's going on. They just want to tell somebody, just sit there and listen. All right. Take it seriously. A lot of people think that it's just, oh, you're just trying to get attention. Oh, this, oh, that, especially with the younger patients. I think we've kind of talked about this during lifespan development. Guys, there are kids 9, as young as 9, committing suicide these days. All right. So don't think that it's just something, you know, a tactic to get attention. Show your patient that you care about them. Do your due diligence to do what? What's something with these psych patients, these patients who are SI or HI, these patients who might come from like an abuse or a neglect case? Who do we need to make sure we get involved at the hospital? Family, if they're there.
Wouldn't you call social services?
So guys, that's not your job to pick up the phone and get like a caseworker, a social services caseworker on this patient's case. But you need to say, hey, during your verbal report, hey, this is going on. They're contemplating suicide. You need to get social services involved. Or it's a neglect case or an abuse case. Remember that you're a mandated reporter and try to be an advocate for your patient. Okay, because if a caseworker is involved, they can do some follow-up care to try to get these patients the resources that they need. Okay?
Professor A, yeah. You said HI and SI. What is that again?
What's SI?
Oh, suicidal ideation.
Suicidal ideations, which means that they're contemplating harming or killing themselves, and then homicidal.
Okay.
Other people. Like, guys, there's a difference between ideations and attempts. Right? They can be thinking about it. They can be coming up with a plan, but a suicide attempt is different from contemplating suicide. Okay? Usually with a suicide attempt, we're going to have some treatment involved, whether that's a medical etiology or trauma treatment. All right? People who are going through a depressive state, that are getting towards the end of that depressive state, that they're planning on harming or killing themselves. There are some certain signs that people can pick up on, because guys, you hear about it a lot, where somebody, you know, takes their own life, and then their close friends and family, they're like, I had no idea. Like, I'm around this person all the time, and I had no clue they were depressed. All right, so if they are, you know, very withdrawn, it seems like they're just apathetic, they don't care about anything. If they've recently been giving away personal possessions, if they've been making plans for, let's say, like a neighbor to come, like, you know, watch their dog, or, you know, financial changes, all that kind of thing, are some kind of some warning signs that they might be contemplating ending their life. All right. risk factors for suicide, guys, there's a lot, right? Especially financial setback. If you lose your house, lose your job, lose a significant other, anything that, you know, happens, like maybe a custody thing or the death of like a child or a loved one. If you're an alcoholic, if you abuse drugs, just be familiar with some of these things in their chart in your book and try to pick up if one of these things is happening to your patient and they're acting this way, then we really do need to be an advocate for that patient. Another thing to think about too, guys, always your scene safety. You hear, you know, murder suicides all the time. If they're dead set, no pun intended, on taking their own life, who's to say that they're not gonna, you know, if you're gonna stand in their way for doing what they want to do, well, I'm about to be dead soon, I'll just take you out too. All right, so just make sure that always, if PD is on scene, I would always, it was a rule of mine, if you were acting erratically or if you had SI or HI, if PD was on scene, I requested that PD would pat that patient down before they got in the back of my truck, just to make sure they didn't have any weapons that I couldn't see. All right. If you don't have PD on scene, it's totally appropriate for your safety and your patient's safety. Hey, do you mind if you just, like, you know, empty out your pocket so I'm good that you're not going to hurt yourself, you're not going to hurt me, you're not going to hurt my partner. All right, that type of thing. PTSD, what happens with this? What does PTSD stand for? Traumatic stress disorder. We kind of talked about this in the first couple chapters about the well-being of working in EMS. We see this a lot with combat veterans. We also see this with first responders. Guys, it's growing with first responders, especially with suicide. Okay, guys, you're gonna see some stuff, and that's gonna bother you. All right, so that's gonna stick with you for a long time. But again, it's part of what we do. Typically, a certain sound or a certain smell or sight can take you back to a traumatic event, like maybe take you back to a really bad call, and you're reliving that stressful situation in your head over again. A big one with a combat veteran is fireworks, because it sounds like a fire, so that can usually kind of trigger a PTSD incident. They might act erratically, violent, suicidal. A lot of times they act on taking their own life when some of this flares up. Guys, always remember, this is another good point, guys. All of this high stress stuff literally kills you quicker. Okay, because you're constantly putting stress on your heart, your vessels, because you're constantly, if you're stressed out, you have that adrenaline flowing through your system. So when they say stress kills, it really does. So just keep that in mind if you stress out a lot. Guys, you've got to also go back to that very first chapter, maybe not the very first chapter, very first module, and remember your legal duty and obligation and terms. Because again, you got a patient who's A&O times 4, you come on scene, let's say a passerby called, and they were driving and they saw somebody kind of pacing on the side of the road talking to themselves. Well, that person driving the car doesn't think that that's normal. They're not going to stop and help. They're just going to call 911 and send somebody out there to check on that person, right? If you get on scene, yeah, that person might be talking to, you know, Billy Joe, like that we can't see. But if they're A&O times 4, if I don't think that they have any SI or HI on board, you got to think about your legality when it comes to kidnapping patients, right? So we don't kidnap and force patients to go to the hospital who have high blood pressure and don't take their medicine, right? If they're having, as long as they're not being violent or erratic or have SI or HI on board, they can talk to Billy Joe Bob, and if they can answer my questions and I'm comfortable with their, you know, stability not to harm themselves or anybody else, you got to remember consent. Okay. Another thing, It's not illegal to be crazy. It's not illegal to have a psychiatric episode. This happens a lot with PD. They will get called out to that person who's talking to themselves on the side of the road, and they go out there and they tell them, hey, you know, go talk to yourself somewhere else or people don't call type thing. But if they keep getting called back to that same person, they'll give them an ultimatum. Look, you can either go to jail with me for public disorder or disorderly conduct or whatever, or you can go to the hospital with Granny. Again, if that patient is A&O times 4 and does not want to be transported, even though PD is trying to push them, I can't kidnap that patient. All right, sometimes someone tries to pull on these psych patients off on Granny because they don't want to keep dealing with going to that same call. So just remember that. Just because a police officer tells you to transport a patient doesn't mean you have to listen. You're that patient advocate and you need to know your rules for consent and kidnapping and assault, battery, and all that stuff. Okay. Everybody good? Questions, comments, concerns? Because what do they fall under? Not alternate mental status if they're A&O times 4. What kind of consent? Even if they're A&O times 4. They're within their right state of mind, but they are giving me proof that they're wanting to harm themselves or somebody else. What kind of consent is that?
Implied.
Involuntary consent. And remember, how do you interact with those patients? Hey man, I know you don't want to go and I don't want to make you do something you don't want to do, but because you said this and this, or because we saw this and this, we've got to go. So again, yeah, if they're not wanting to go. Because again, that situation could progress into a violent situation if you're like, you know, trying to throw your weight around saying, well, you're going with me whether you like it or not, type thing. So just remember that. All right? All right, everybody good? Everybody good in Zoom land?
I have a question to kind of backtrack.
Yeah.
So with someone who's having like a general seizure, you know, let's say they're standing up and like they fall and like there's spinal trauma, would we attempt to stabilize the spine? You know, if they're seizing and they're obviously convulsing everywhere, is that
So how are you going to know if there's spinal trauma if you can't assess them because they're convulsing?
Wait, what?
So are you saying, are you going to try to stabilize their spine while they're seizing?
Yeah, well, I'm saying like, how would that work?
You're not going to be able to do any assessment or any real treatment until they're postictal.
Okay.
So yeah, guys, again, trauma injuries are pretty common with tonic-clonic seizures, especially if they're standing up and they fall, or if they fall down a flight of stairs while they're seizing. So once they hit that postictal state, do that head to toe assessment, find any injuries and treat them.
Okay, thank you.
So while they're seizing, you're basically just monitoring them?
While they're seizing, the only thing that we're doing is maybe putting a non-rebreather on them and making sure they don't like hit their head on something or fall off of something. We're just trying to prevent them from having any further trauma.
So after they're seizing and they're in the postictal care, you would see if they had cervical, like the C-spine damage. Mm-hmm. So that would also prevent their head to get rid of the vomit. So you would just suction. So you can do, it just depends all on their spine, pretty much.
Right.
At that point. Okay.
No. Yeah, guys, that's because wait. Oh, we didn't watch the fire drill video, did we? Oh, no. Anyway, yeah, that's an old wives' tale that somebody would put like a leather belt in somebody's mouth, or like a, you know, something in their mouth while they're seizing because they don't want to swallow their tongue. That doesn't happen. Most of the time, you're not going to be able to get anything in their mouth because their jaw is going to be clenched. So yeah, we don't insert anything in a patient's mouth while they're seizing.
I have another question.
Well, you had an okay in a patient's mouth already, and they started seizing when they go to bite through it. Like, how strong are
It's
those?
possible, but no, they're pretty durable. Question.
With seizures, you know, you're saying that they can get hypoxic while they're seizing. With something where, like a prolonged seizure, is it possible to see like brain damage?
Yeah. I mean, because you hear about it a lot, or maybe not a lot, but there was recently, and guys, I only know this because my 3-year-old watches Disney Channel, but one of the actors in some of the big Disney movie lately had a seizure disorder. Huh? Yeah. And died from the seizure. And usually when you die from a seizure is secondary to that prolonged hypoxic state.
Okay.
So yeah, that can definitely happen. All right.